Hi everyone. So here's our diabetes drug spreadsheet. I just want to go over a few things. I have it organized so that here are your insulin types. There are 4 different types of insulin here. There's rapid acting, short acting, intermediate, and long acting. Names that all of these names you're going to use a lot. We'll use Aspart, Lispro for fast, regular for short, NPH for intermediate, and then Glargine and Detamere or Lantus and Levemir for long acting. The difference between these are the onset, peak, and duration of their times that they work. So let's take a look at 2 that go together very well, which is rapid acting and then long acting. So a diabetic's blood sugar is high, and the doctor will order Lantus or Levemir to be given once or twice a day. The duration of this, which is how long it lasts for in your system, is 24 hours. There's no peak. Peak is when the medication itself is peaking in its effect. So there should be no peak where the patient might have to eat at a specific time. And the onset is about 1 hour. This is great for keeping a patient's blood sugar nice and stable or slightly lower than normal throughout the entire day. Along with this long-acting insulin, patients are typically given rapid-acting insulin, such as Humalog or Novolog, Aspart, or Lispro. These act very fast once injected. The onset is about 15 to 30 minutes. Patients are usually told to administer this 20 minutes prior to eating. The peak is 30 minutes to 2.5 hours. That means that's when it's going to work the most in the body. That's when it's going to have its biggest effect, is between 30 minutes and 2.5 hours. This is great because this is the time period that carbohydrates are ingested in our body. That's why we inject it about 20 minutes prior to eating, so that there is less ups and downs within the blood sugar. It lasts for about 3 to 6 hours. We use this rapid acting along with the long acting right here because this is what we're going to use to bring down high blood sugars to normal blood sugars, just like that sliding scale, or give ourselves insulin depending on the number of carbohydrates that we eat. Now that is going to be determined by the physician. It will be an ongoing process and it might evolve and change. Okay? So there's no steadfast way of us to determine how many units per carb a patient needs, and nor is there any reason for us to. Basically, insulin, like we said before, it, speaking of its action, it allows that gate to open and the glucose to be uploaded into the cells for energy. We see regular insulin, which is the short-acting insulin, quite a bit as well. That onset is 30 to 60 minutes. The peak is 1.5 hours, and the duration is 6 to 10 hours. Short-acting insulin, or regular insulin, is typically given with intermediate-acting insulin, or NPH. As you know in the lab, we mix these 2 insulins. In real life, we do not. There's too much of a cross-contamination between these 2 medications that can happen while drawing up the medication. In some cases, the pharmacy will mix them together for you, or we will just give 2 shots, one of regular, one of NPH. So we have our short-acting regular, which peak is 1.5 hours, and then we have our intermediate, which in peak is 6 to 14 hours. The elderly population seem to use this combination a lot because it means less insulin shots per day. They can give themselves this combination in the morning and then in the afternoon, and they have to have a very strict regimen of the carbohydrates that they eat per meal, and they have to be eaten at certain times. This is when that diabetic diet, people seem to think that diabetics are on, this is what that means. They have to eat certain carbs at certain times of the day in order to help this short-acting and intermediate-acting work and to prevent them from going into hypoglycemia. The long-acting and the rapid-acting are used together. This is the newer regimen that is out there. It works very well. There are additional shots involved. However, you give yourself insulin based on the carbs that you're eating. That means that you don't have to be so regimented with the amount of carbs and the time that you eat. Going down the screen a little bit here, the action for all of these are the same. The indications, of course, is diabetes. We also use this for ketoacidosis. Not many contraindications except for allergies, stress and infection. Insulin requirements are increased. If you're vomiting, your insulin requirements are decreased if you're not consuming carbs. You can have hypoglycemia with this insulin. It can bring you down too much. You could be allergic to it. Also, you could have something called lipohypertrophy. That is when a diabetic will give themselves their subcutaneous shots in one location, and pockets of fat form underneath and scar tissue form underneath, which does not allow the insulin to be absorbed anymore. This is why we rotate our injection sites to prevent that from happening. We talked about ACE inhibitors and beta blockers within the PowerPoint. As far as nursing care is concerned, you need to educate the patient on the types of insulin, their peaks, and make sure that they understand this. It'll be repeat education by both yourself, the physician, and hopefully a diabetic educator that's in the hospital. Fast acting, you need to monitor glucose very frequently. If you're a type 1, you might be doing this 8 to 10 times a day unless you have a continuous glucose monitor. You will have a sliding scale for the correction, and every once in a while you will need to get labs drawn. Your hemoglobin A1C will be drawn every 3 months. Over now to the PO medications for type 2 diabetics, although type 2 diabetics can also take insulin if required. So we have the biguanides and the DPP4 inhibitors, and then the sulfonylureas. You're going to be seeing the sulfonylureas fairly often, actually all 3 of these fairly often. The biguanides are metformin. This is a very common type 2 diabetic drug. It works very well. The other is the sulfonylureas, the glycoside. And then lastly, the Januvia, which is fairly newer on the market, which is a DPP4 inhibitor. So let's talk about metformin for a moment. Metformin reduces the production of glucose in the liver, so it works in the liver. So that said, it's probably a little bit hard on the liver, right? It suppresses the gluconeogenesis, increases glucose uptake, and uses in the muscle for first choice med for type 2 diabetes. It is in conjunction with lifestyle changes and caution with patients with hepatic dysfunction, renal dysfunction, severe infection, and hypoglycemia. So of course, when you think of this, you think, well, diabetics can have renal dysfunction. Yes, and this works on the liver. Yes, so we always need to monitor the labs and make sure that this medication is not harming them. Once you start taking insulin, you should avoid alcohol and iodine. Hold on, I'm just checking. You need to monitor for hypoglycemia, keep a blood sugar log and food intake, and then they should be taken with meals, except for extended release tabs. Down here for for Genevia, also promotes the release of insulin and decreases secretion of glucagon. So that means it decreases the secretion of glucagon from the liver. Okay. This is a very similar product to the sulfonylureas. Of course, caution with renal and hepatic failure. Again, that's the same as sulfonylureas. And we want to monitor, again, side effects for hypoglycemia. And this one is to be taken once a day without food. The sulfonylureas, which is the glycoside, this releases insulin from the pancreas. You see how there's a little bit difference here? We've got reduces production of glucose in the liver, or metformin, and then Genevia promotes release of insulin and decreases secretion of glucagon. And now the sulfonylureas, they release insulin from the pancreas. Again and again, we also know on hepatic dysfunction and monitor signs and symptoms of hypoglycemia and take with breakfast. The reason that we have these different ways of administering, take with breakfast, take with food, is all due to the chemical makeup and how they are going to be metabolized within the stomach. We have glucagon here. This stimulates the hepatic production of glucose from glycogen stores. Basically, it says release the blood glycogen in the form of glucose from the liver to the body to increase the amount of sugar in the body. This obviously is for acute severe hypoglycemia when administration of orange juice cannot happen. If you give glucagon, you do need to call 911 right away as a backup because it could wear off depending on the amount of excess insulin that's in the system. This does need to be reconstituted. So we need to educate the family on how to reconstitute and inject into the patient. Most of these people have not given an IM injection before. This is a family member. So a lot of education needs to be completed on this. Patient might go into seizures and they might be given this IM shot while having a seizure. So a lot of education needs to go into this. Also remind them that the first time they do this, they might not do it right. And that is okay. Our body itself will release our glucagon storage from the liver if it realizes we're in such a dangerous spot. However, if you don't have enough glucagon in your liver storage, that's not going to happen. And neither will this glucagon gun. That's why it's imperative to call 911 as you're realizing that you're going to need to do this. Glucose, the 25 grams of D50 IV push. This just provides immediate glucose into the vascular system for severe hypoglycemic events. This is the easiest way for us to get sugar into the patient while they're in the hospital. We need to follow the protocols with this, and we check blood sugars every 15 minutes, monitor the neurological and the cardiac status, right? We were talking about potassium and everything before, and make sure to give them a protein and carbohydrate snack once they have come to with that D15. Most of these patients are not alert oriented and have to have it this way in order for us to get the blood sugars up. I will not be talking about the following four, so don't worry about that for now. Thank you.